Our health is influenced by many aspects of the world around us, from our individual genetics and behaviours to the social and physical environment we live in. The wider determinants of health is a term used to describe these latter influences, the diverse range of social, economic and environmental factors we experience daily. Some are directly linked to health outcomes, such as air pollution, whereas others operate less directly, such as employment status. The wider determinants determine the extent to which different people have the ability to meet their needs and deal with challenging circumstances. Such factors make a large contribution to variation in health outcomes. Several studies have attempted to estimate the contribution of the wider determinants to population health, finding that they account for 40 to 50% of variation, a greater influence than healthcare, individual behaviours, or genetics. But the daily conditions in which we live are not straightforward to influence, being shaped by the distribution of local, national and international power and resources. The wider determinants affect our health through dynamic, interrelated and looping causal pathways that cross individual, social and environmental contexts. Dahlgren and Whitehead attempted to capture this complexity in this diagram, where the wider determinants are the multiple contextual layers that wrap around the individual lifestyle factors. When looking into specific issues, logic diagrams can be helpful to communicate pathways from wider determinants through intermediate factors to health outcomes, such as in this example from Public Health England's recent Spatial Planning for Health document. Variation in how people experience the wider determinants, that is social inequality, is considered the fundamental cause of health inequality. Therefore, irrespective of whether intermediate causes change over time, health inequalities are likely to persist so long as social inequalities persist. Such complex systems are perhaps contrary to the typical approach to public health interventions, where actions tend to focus on individuals and causal pathways are simplified. However, it is important to keep this complexity in mind when thinking about how to reduce health inequalities. There is a strong and persistent social gradient in health outcomes. For example, life expectancy at birth varies substantially by about 12 years across the deprivation deciles. This gradient is maintained across the social distribution, just as those in lower social positions have on average worse health outcomes than those higher up. Those near the top of the social hierarchy have on average worse health outcomes than those at the very top. Social inequality drives health inequality because those in lower social positions are more likely to be exposed to negative social and environmental factors. This is obvious for those factors which are constituents of social position, such as relative income, but it is also the case where social position indirectly increases exposure to these factors, such as to excessive noise, air pollution, or crime. The Marmot Review suggests that to reduce health inequality, action must be taken universally across the social gradient, but recommends proportionate universalism, with a scale and intensity of action which is proportionate to the level of disadvantage. Looking at measures of wider determinants broken down across measures of social position provides insight into how these determinants of health are often unequally and systematically distributed across the population. Some examples follow. Education is strongly associated with health outcomes. Higher attainment is related to better employment and earning opportunities, as well as a range of wider health-promoting behaviours. Evidence from studying child cohorts suggests that differences in relative cognitive performance between children from different socioeconomic groups tends to widen as children get older. And in addition, of those children who had a relatively low cognitive score at age 22 months, children of educated or wealthy parents tended to have a relatively high cognitive score by age 10, whereas children of worse-off parents were unlikely to improve. A range of issues related to children and young people's health through the education system are covered in these documents produced by Public Health England. There is a strong association between income and many health outcomes, with health outcomes improving incrementally as incomes rise. It is thought that the gradient between income and health outcomes is steepest at the lower end of the income distribution. That is, smaller differences in income are associated with larger differences in health when income is low. The minimum income standard is based on research into what members of the public consider as necessary for a socially acceptable standard of living. As well as food, clothing and shelter, it's about having what you need to have the opportunities and choices necessary to participate in society, and so it fits with the complex ways in which income can influence health over the life course. The minimum income standard measure was first produced in 2008-9 during the most recent recession.
Since then, there has been an increase in people living in households below the minimum income standard from 26% to 30% of all individuals in England by 2014-15.
Looking beyond the average level exposes the different prevalence of low income across the population. The South East has consistently had the lowest percentage of people living in households below the minimum income standard, whereas London has had the highest. In 2014-15, 45% of children lived in households below the minimum income standard, up from 39% in 2008-9. This compares to 15% of pensioners. The children most at risk live in lone parent families, where 75% live in households with an income below the minimum income standard. Lone parents who do not work have the highest prevalence of being below the minimum income standard, at around 95% since the measure began. For lone parents in full-time work, the prevalence of falling below the minimum income standard has been increasing since 2009-10, from 28% to 42% in 2014-15. The relationship between low income and health inequalities is explored in this document produced by Public Health England. Housing affects people's physical and mental health through a variety of channels, such as hazardous homes, including cold and damp accommodation, the mismatch of a home to a household, including overcrowding, or poorly adapted homes to meet the needs of an older person or person with a disability, and unsafe and unstable living circumstances, with homelessness being an acute manifestation of such instability. Unsurprisingly, being exposed to housing problems which are bad for health is associated with social position. For example, fuel poverty is estimated to be around 3 times higher among those who are unemployed at 28% compared to those who are working at 9%. There is also a strong social gradient in overcrowded households. The 2011 census showed that overcrowding was 3.5 times more prevalent in local authorities in the most deprived decile compared to those in the least deprived decile, with a clear gradient between the two. Public Health England have produced a series of resources and guidance on improving health through the home, which are available online. For more examples, Public Health England's Wider Determinants of Health web tool brings together a range of indicators which describe variation in wider determinants across local authorities in England. It presents indicators, provides some descriptive analysis, and links to further resources to promote action.